Hello, my name is Kristy Meiselbach and I'm a Research Assistant at the Centre for Health Policy at the University of Melbourne. Welcome to my presentation, Factors Influencing the Use of Familial Cancer Genetic Services for Indigenous Australian Populations. Before beginning my presentation, I would like to acknowledge the land on which we all stand today. Myself standing on Wurundjeri land. I would like to pay my respects to the Wurundjeri elders, past, present, and future. I would also like to pay my respects to my Gunditjmara elders and ancestors, hoping their spirits guide and protect me. In Australia, the mortality rate for Aboriginal and Torres Strait Islander people diagnosed with cancer is 1.4 times higher than for non-Indigenous people, despite having only a slightly higher overall incidence rate. Aboriginal and Torres Strait Islander people diagnosed with cancer also have a lower 5-year survival rate following a cancer diagnosis compared to non-Indigenous Australians. The reasons for this observed difference in mortality are multifaceted and reflect a complex interplay between risk factors such as a relatively higher burden of comorbidity, experiencing more barriers to accessing health services, and less uptake of these when they are available. The result is that overall, Aboriginal and Torres Strait Islander people in Australia are diagnosed at younger ages and with more advanced stages of cancer. While shared environmental risk factors within families are likely to be the most significant contributor, heritable risk conferring alleles will underlie this observation in a proportion of families, as familial cancers account for 5 to 10% of all cancers. Improved access to cancer screening and surveillance, including the use of clinical genetics and genomic technology to inform prevention, diagnosis, and treatment, has the potential to reduce the burden of cancer in Indigenous populations. In particular, given the high rates of cancer diagnosis clustering within families. Geographical, socioeconomic, and cultural barriers experienced by Aboriginal and Torres Strait Islander people are likely to contribute to their underuse of these health services. Now, what is a clinical genetic service? Clinical genetic services provide diagnosis, risk management, patient management advice, and counselling for people and families affected by chromosomal or single gene conditions. They are able to order genetic and genomic testing where deemed appropriate. They do not undertake population-level screening. There are two kinds of services: clinical genetic services and familial cancer clinics, which both offer a different model of care. Both familial cancer clinics and clinical genetic services are equipped to consult with patients who either have a personal or family history of cancer and undertake relevant genetic testing as appropriate to individual cases. Both models of care provide genetic counselling to support patients throughout the testing process, from deciding whether to have the genetic test, to receiving results, treatment strategies for surveillance and cancer prevention for those with informative results, and how to inform relatives. FCCs are staffed by multidisciplinary teams, including clinical geneticists, genetic counsellors, medical oncologists, oncology nurses, and specialist surgeons, and are therefore able to cover all aspects of patient care in-house. CGS, on the other hand, stand alone from other aspects of the patient's cancer care or screening management, and are most often accessed by referral from another medical practitioner. Importantly, many people who attend clinical genetic services at most a handful of times, whereas those attending a familial cancer clinic may do so periodically over many years. The analysis was used to capture both the experience of the patient and to inform an appropriate health system response. The aim of the project was to identify the barriers and enablers of attendance to clinical genetic services by Indigenous Australians suffering a personal or family history of cancer. Interviews were conducted with eligible participants. These interviews were then used to identify key barriers and enablers to service attendance and identify common overarching themes. The analysis was used to capture both the experience of the patient and also to inform an appropriate health system response. The four main factors influencing people's experiences were the opportunity to benefit family, availability of follow-up support, appropriate communication and empathetic genetic counselling, experiences of racism and provision of culturally safe care, including the lack of Indigenous representation in genetic services. Two databanks were used for this analysis. The Better Indigenous Genetic, or BIG, Health Services Project, which investigated the quality, acceptability, and effectiveness of clinical genetic health services for Indigenous Australians, covering 4 delivery models in 3 Australian states or territories, including Western Australia, Queensland, and the Northern Territory, as well as the Kathleen Cunningham Foundation Consortium for Research into Familial Breast Cancer, or KCONFAB. This is a national resource for familial breast ovarian cancer genetic research, based at Peter MacCallum Cancer Centre in Melbourne. Participants of KCONFAB are recruited by familial cancer clinics across Australia and New Zealand. It includes people with at least one family member who has accessed genetic services for breast and/or ovarian cancer risk assessment and genetic testing. Participants were identified through Northern Territory Genetic Services, Genetic Health Queensland, Genetic Services of Western Australia, and KCONFAB. People who had self-identified as Aboriginal and/or Torres Strait Islander when completing their baseline recruitment for KCONFAB or on intake at one of the genetic services between 2015 to 2018 were invited to participate. Eligible participants were sent an invitation letter, plain language statement, and consent form by post. An opt-out approach was employed, such that invitees who do not want to take part in the project were asked to indicate whether the research team by phone, email, or post. Anyone who had not responded 3 weeks after the invitation was sent a follow-up by phone. Out of 31 eligible participants identified from the KCONFAB database, 16 indicated their interest in participating, and 14 completed interviews. All belong to families with a very strong history of breast and/or ovarian cancer, had attended a genetics clinic, and knew that they carried a clinically significant germline mutation. The interviews allowed participants to describe and discuss their experiences at each step of the patient journey when accessing the clinical genetic service. It is a key principle in Aboriginal and Torres Strait Islander research that the key to improving health services for Aboriginal and Torres Strait Islander peoples requires understanding how services are working from an Aboriginal and Torres Strait Islander perspective, and incorporating this into the design and governance of services. We ensured Aboriginal and Torres Strait Islander research governance throughout multiple aspects of the project, and used an analytical approach designed to privilege Aboriginal and Torres Strait Islander perspectives in all aspects. Family was a central theme in all discussions with participants. A number described the decision to access a clinical genetic service was a family decision rather than a personal one. The potential benefits to relatives and future generations, including the opportunity for them to take preventative measures to stay healthy, was the primary motivator for attendance for many people. Among our participants, it was more often a family member than a health practitioner who suggested they consider attending a clinical genetic service. The opportunity to discuss a strong family history of cancer with a genetics practitioner allowed some families to understand a history of an illness and premature death among relatives, empowering them to make their own decisions about preventative measures and support younger family members to do the same. Participants also described how attending a clinical genetics service served as a driving force for having conversations about the importance of monitoring and preventative measures with their family. Family was also the key source of emotional support for participants. Two enabling factors that emerged from our study were a sense of clarity and support offered by attending a clinical genetic service. Some participants decided to access genetic testing because it offered clarity, while another referenced the psychological benefits, often expressed as a sense of relief because not knowing is worse than knowing. Receiving an informative genetic test could pave the way forward for improved surveillance for cancer prevention and treatment. Being provided specific information or a letter from the geneticist explaining the outcome of their attendance was found to be very useful by patients for sharing with or facilitating an explanation of what their diagnosis meant for other relatives, to make sure they were all on the same page. The first barrier we identified was issues with communication around genetic testing, preventative measures, and treatment. The availability of adequate genetic counselling was variable among participant experiences. While several participants described their genetic counsellor as fantastic, others had scarring experiences. One participant described feeling compelled to have life-altering preventative surgery at a young age after just one counselling session, and I don't even think you could call it a counselling session. I was probably there for 10 minutes, the participant described. In some cases, no genetic counselling was available. Another participant expressed a similar sentiment, having little explanation or counselling when being advised that they needed to undergo a major life-changing surgery, including the implications that the treatment would have long-term. Some patients felt overwhelmed and that the process and being told that she was a mutation carrier was quite a lot to absorb. Whilst it was explained to some patients how their mutation status may affect other family members, others were given little to no explanation. The second barrier that emerged from the interviews was the impact of inherent racism in the medical community. One participant described, "Sometimes when you see an Aboriginal person coming into a doctor's surgery or wherever, you can see people's faces change. Some medical people look away, and that's not right." Participants expressed the desire to not identify as Aboriginal in their healthcare records, having a mentality of "don't tick that box" for fear of racism, referring to self-identification of Indigenous status on their health records. The third barrier presented is a lack of cultural representation for Aboriginal persons working in genetic clinics. Participants described a lack of cultural input in their experiences with genetic health services, with one participant explaining that there was no cultural input in their experience and little to no representation of Aboriginal persons or culture at these services. Participants expressed that they felt there was a lack of information about genetic health services among Aboriginal populations. One participant discussed their feelings that Aboriginal communities are unaware of what is available to them in terms of genetic services, specifically in terms of what is available for little to no cost to persons from at-risk families. Our study has identified some key areas in which genetic cancer services should improve in order to deliver more culturally safe and appropriate genetic services to Aboriginal and Torres Strait Islander patients. This includes creating more primary care linkage pathways in order to provide higher quality and coordinated care, addressing discrimination and racism within services through education and training, as well as building the Aboriginal and Torres Strait Islander workforce within the genetic services paradigm. It was clear from the interview analysis that many of the Aboriginal and Torres Strait Islander patients were highly motivated to improve outcomes for their family by undertaking genetic testing. Many found genetic testing to have a positive psychological benefit, as well as empowering them to assess their individual risk and take control of their own clinical journey. By addressing the barriers affecting Aboriginal and Torres Strait Islander peoples at the service level and understanding both motivators to attend and factors facilitating engagement, genetic service providers can begin to make a more positive change to improve engagement of Aboriginal and Torres Strait Islander peoples in genetic testing related to cancer. Family Cancer Care Clinic's model of care is highly consistent with the needs of Aboriginal and Torres Strait Islander peoples. There should be particular focus on improving cultural competency in this model. Aboriginal and Torres Strait Islander people are underrepresented at both the clinical genetic service and familial cancer clinics. Based on our findings, targeted action to improve access and engagement among Aboriginal and Torres Strait Islander populations at familial cancer clinics in particular has great potential to achieve better outcomes for Aboriginal people and families affected by cancer. Thank you for listening to my presentation today. And I would also like to thank all the contributors and funders to this research project.